Welcome to the deep dive. Today we're taking on a really comprehensive journey through one of the most structurally complex fields in medicine, the surgical anatomy and technical approaches to the entire spinal axis.
That's a great way to put it.
If you're a medical student, a resident, or maybe a young professional looking to build that fundamental armamentarium for spinal issues, this session is basically your navigational chart.
It really is. And the core idea from all our sources is that modern spinal surgery is, evolving at this breakneck speed.
New instruments, new techniques everywhere you look.
Exactly. New instrumentation, minimally invasive approaches, options from occipital cervical fusions all the way down to sacroiliac fixation. But despite all that change, the one constant, the thing you have to rely on, is a mastery of the fundamentals.
Anatomy and technique.
Anatomy and meticulous technique. So our mission here is to review those essential approaches across the entire spine, just to make sure that foundation is rock solid for you.
Okay, let's unpack this starting at the absolute top, the most delicate, biomechanically challenging region of all. The craniovertebral junction, the CVJ. This area involves the clivus, the foramen magnum, C1 and C2. When you're facing lesions on the anterior side, the choice often comes down to the transoral approach, the TOC, or the high cervical retropharyngeal approach.
Right, and the TOC is your direct line of sight. It's really well suited for those anterior extradural lesions of the CVJ, but the technique, it demands incredible precision.
Not just precision, but I imagine depth perception is everything.
Everything. The surgeon has to clearly define the boundaries of the C1 arch, the C2 body, the dens, and the clivus. And exposure is key, which often means splitting the soft palate and the posterior pharyngeal wall.
And here's where it gets really interesting for our listeners. The lengths the surgeon has to go to for that exposure. If the pathology goes way down, say to C5, the procedure might need what the sources call a midline glossotomy.
Yes.
You mean literally splitting the tongue?
Literally splitting the tongue to gain that inferior line of sight. And because you're operating through the mouth, the oropharynx, the risks are significant, specifically instability and infection.
Okay, so if the surgery involves removing the dens and odontoidectomy, what happens then?
The patient is immediately unstable, period. That means they will require either immediate or delayed posterior stabilization, usually an occipito-cervical fusion, before they can even think about getting out of bed safely.
And that infection risk has to be high, given the field is inherently contaminated. So if the dura gets opened, what does the post-op management look like?
It becomes a critical situation. You've basically opened a direct line for oral bacteria into the subarachnoid space. So management has to be meticulous. You need a patch secured with fibrin glue, a lumbar drain to lower CSF pressure and help the dura heal, and of course broad-spectrum antibiotics for at least a week.
Okay, now let's look at the alternative. The high cervical retropharyngeal approach, or HRC. It sounds like it has a massive advantage right off the bat. It avoids opening the oropharyngeal mucosa.
That's the theoretical advantage, and it's compelling. You sidestep all those high infection risks.
So why isn't it used more often?
Because of the enormous clinical trade-offs. You gain infection control, but the trajectory is awkward. It's not a direct midline approach. The exposure is much, much deeper. It requires a lot of soft tissue mobilization, and that means long operative times.
And more morbidity, I assume. If the trajectory is that deep, how often does it require something like a prophylactic tracheostomy?
Quite often, actually. Because of all that anterior neck dissection and the potential for swelling, and even more critically, anatomically, you've got the superior laryngeal nerve running deep to the internal carotid artery. It is highly vulnerable.
So a stretch injury or even a thermal injury from retraction could damage it.
Right, and that impacts voice quality, swallowing function. So you're trading a huge life-threatening instability and infection risk with the TOC for a significant function-altering morbidity risk with the HRC. It's always a trade-off.
That really highlights it. Knowing the anatomy dictates the whole operation. Let's shift down to the mid and lower cervical spine, where it's mostly degenerative disease and trauma. We have to start with the workhorse. Anterior cervical discectomy and fusion, or ACDF.
ACDF is the go-to. It treats any condition, degenerative or traumatic, that's impairing the nerve roots of the spinal cord. You're doing a direct anterior decompression. You remove the disc, the bone spurs, and sometimes the posterior longitudinal ligament, the PLL.
The sources outline two classic techniques here, Cloward versus Smith-Robinson. Can you just clarify that distinction for us?
Sure. Cloward was historical. You used a cylindrical drill to remove a circle of disc and end plate, then you'd place a dowel graft. The Smith-Robinson technique is much more common today. It's a rectangular bony resection.
Which allows for a better prep of the end plates for modern cages.
Exactly. It's just much more accessible.
Okay, for the approach, we're using that standard anterolateral corridor. Carotid sheath goes lateral, trachea and esophagus go contralateral. But let's get into the technical nuggets. When you're doing the decompression, how do you know definitively that you've removed all the compressive stuff?
Great question. First, you use Casper pins. They go in the mid-portion of the vertebral bodies, and you angle them slightly up, cephalad. They aren't just for fixation, they're a fulcrum.
So they let you distract the space.
Precisely. You open the disc space to help you get the osteophytes out. Then, once everything is removed, you have to confirm complete decompression. And you do that by feel. You take a blunt micro hook and you palpate the floor of the neural canal and the foramina. You have to ensure the dura and nerve roots are completely free.
It's purely a tactile maneuver. You can't just rely on what you see.
You can't. You have to feel it.
Makes sense. Now let's compare that direct anterior approach to the posterior options for multi-level myelopathy, laminectomy versus laminoplasty.
Okay, laminectomy is the traditional route. You remove the spinous processes, the laminae, right up to the phaffet joint. It's fast, but it carries some well-documented, potentially severe disadvantages.
Like instability and post-laminectomy kyphosis.
Exactly, and neural scarring. It's generally best reserved for older, low-demand patients who still have a good cervical lordosis, a good curve in their neck.
Why does laminectomy cause kyphosis? Is it just from removing the bone?
It's multifactorial, but fundamentally, you're removing the posterior tension band, the ligaments, the muscle attachments. You denervate those muscles, and you take away that mechanical stability. So over time, gravity just pulls the neck forward into kyphosis.
Which can actually worsen the cord compression you were trying to fix.
Paradoxically, yes. And that's exactly why laminoplasty was developed, to prevent that complication.
So how does laminoplasty achieve decompression indirectly? It seems almost counterintuitive.
It's a brilliant biomechanical trick. You create a bony hinge, so the Hirabayashi open door procedure. You cut one side of the lamina completely and make a trough on the other side. You then lift the whole lamina spinous process complex like a door.
And you prop it open with little plates?
Right. And this creates a massive enlargement of the canal. It doesn't remove the anterior compression, but it lets the dural sac drift backwards, away from it.
And the big clinical advantage is that you haven't destabilized the spine, so you don't usually need a fusion. You preserve the range of motion.
That's the goal. The choice between anterior, which is direct removal, and posterior, which is indirect expansion, comes down entirely to sagittal balance. If the patient is already kyphotic, posterior decompression is basically useless. The cord is still draped over the front.
But if they have good lordosis, the cord can drift back successfully.
Exactly.
Okay, moving on to the thoracic and thoracolumbar regions. This is challenging. Accessing the anterior column here is highly invasive because of the chest cavity. Let's start with the posterolateral options, LCA and costotransversectomy.
So, LSA lateral extracavitary approach is a favorite for surgeons who need maximum control. Its key advantage is providing circumferential decompression and stabilization at the same time, without going into the pleural space.
That's a massive win. You're reducing post-op morbidity right there.
A huge win. It lets you directly address midline ventral pathology, all from a posterior incision.
And costotransversectomy sounds similar, but I gather the access is more limited.
It is. A costotransversectomy, where you remove the rib head and transverse process, gives you a much narrower window to the anterior column. It's fine for a small lateral disc herniation, maybe, but if you have a massive central tumor that needs a full corpectomy, LSCA is far superior.
Then you have the big guns, anterior thoracoabdominal and transthoracic approaches. These are for when you need maximum visualization for, say, major tumor resections or scoliosis correction.
Non-negotiable in those cases. The thoracoabdominal approach is often for the thoracolumbar junction, T12 to L2. And this is a complex dissection. You absolutely have to enter the pleural cavity.
And that means dealing with the diaphragm.
You have to identify and detach the crust of the diaphragm and reattach it meticulously, and then you split the psoas muscle. And crucially, you have to ligate and divide the segmental vessels that run over the vertebral bodies to get safe access.
That complexity just skyrockets the risk profile. You're managing lung and diaphragm issues, you need a chest tube post-op. Why accept that trade-off?
Because it's the only way to get that direct, full, front-on visualization you need to insert a large strut graft perfectly, correct severe deformity, and get high-quality fixation over shorter segments. When the disease is massive, maximum access is the safest route.
Got it. Let's jump now to the high-stakes anatomy of the lower spine, specifically anterior access for interbody fusion, ALIF.
The anterior lumbar interbody fusion. Yeah, this requires a very careful retroperitoneal approach. And the surgical risk here is all about critical vascular and neurological structures.
Okay, so let's break down the vascular challenges. What's the difference between working at L3 to L5 versus L5S1?
For L3 to L5, you are right next to the great vessels, the aorta and the vena cava. They have to be mobilized. You typically use a left lateral aortic route because the aorta handles retraction a bit better than the thin-walled vena cava. For L5S1, the corridor is a bit easier. You use the interiliac window between the common iliac vessels.
But the real landmine here is neurological, right? The superior hypogastric plexus.
Precisely.
Mm.
This is a dense bundle of sympathetic fibers that controls ejaculation in males and the internal bladder neck. It lies right over the L5S1 disc space.
And damage from, say, monopolar cautery could be devastating.
It can cause retrograde ejaculation. It is a significant functional complication, and it requires mandatory pre-op counseling. And it's essential to remember that about 80% of those sympathetic ramifications are on the left side of the aorta. So a left-sided dissection path is marginally safer if you can avoid the plexus entirely.
And you can't forget the ureters.
Never. The ureters are draped medially with the peritoneum. You have to identify them and gently retract them before any sharp dissection starts.
Okay, switching gears to minimally invasive lumbar techniques, MED or METX systems. The whole rationale is minimizing that collateral damage to the paraspinal muscles.
Right, you use muscle dilators and tubular retractors to just spread the muscle instead of cutting it. And the benefits are well documented.
Yeah.
Less blood loss, significantly shorter hospital stays.
I saw reports as low as 7.7 hours.
It's incredible.
Yeah.
And a dramatically quicker functional recovery with outcomes that are equivalent to a traditional open discectomy.
Let's talk about transforaminal lumbar interbody fusion, or TLIF. How is it an improvement over its predecessor, PLIF?
So TLIF is really an evolution of PLIF. PLI required a bilateral approach, a lot of exposure. TLIF is unilateral. You access the disc space through the neural foramen. And the mechanical genius of it is that it preserves the important ligamentous structures.
The anterior and posterior longitudinal ligaments.
Exactly.
Why is preserving the PLL so beneficial for the fusion?
Because when you insert that cage or graft transforaminally and rotate it into place, those ligaments act as a natural tension band. They force the graft into compression against the end plates.
Ah, so you get immediate stability.
You get immediate stability, you decrease epidural bleeding, and you reduce the overall risk of nerve root injury compared to the bilateral exposure of a PLIF.
To wrap up, let's hit on the general surgical principles that apply everywhere, starting with internal fixation and pedicle screws.
Pedicle screws are the backbone of modern stabilization. They offer immediate rigidity, higher fusion rates, and they can correct deformity. In trauma, like a thoracolumbar burst fracture, we often use an indirect reduction strategy.
What does that mean?
You put screws above and below the fracture, and then you apply distraction or cantilever forces. This relies on the intact posterior annulus being stretched taut, which pulls the bone fragments that were pushed into the canal back out. You decompress the canal without ever going to the front of the spine.
That's clever. And what about bone grafting? The classic autograft versus allograft debate.
Autograft, usually from the iliac crest, is still the gold standard. It has all three components for bone growth. It gives you the highest fusion rate. But you have donor site morbidity,
Chronic pain, nerve injury.
even fractures. So allograft rings or modern cages made of PEEK or titanium are common alternatives. You sacrifice the living cells for zero donor site morbidity. It's another trade-off.
Finally, infection management, like discitis. If the infection is in the anterior column, is an anterior debridement always the answer?
Generally, yes. The infection is usually in the front, so you need to go in for the front for a radical debridement, get all the infected tissue out, and then reconstruct with a strut graft to restore stability.
What's the key technical detail for placing those grafts?
They absolutely must be countersunk into the vertebral bodies above and below, or fitted perfectly end plate to end plate. You can never, ever rely on screw purchase in infected or pathologic bone. It will fail. The graft itself has to bear the load.
That brings us to the end of an intensive but really vital deep dive. What we've seen is that from the CVJ down to the lumbar spine, successful surgery isn't just about having the right tech. It's about knowing the anatomical implications of every single move.
Absolutely. The decision-making is as complex as the anatomy itself. And to reinforce that critical knowledge, here is a final review prompt for you to think about.
Okay.
Imagine you were planning an L4-L5 interbody fusion. Based on our deep dive, name 3 critical neurovascular structures you must protect during an anterior lumbar interbody fusion ALF approach at this level, and describe the specific complication associated with the one structure most at risk from electrocautery.